Hello, everybody. Thank you for coming. My name is Jenya Cassidy, and I work with the Labor Project for Working Families and the Work and Family Coalition. And welcome to this briefing on maternal and child health. We are co-sponsoring it with the California Legislative Women's Caucus and the California Commission on the Status of Women. And we have a really great speakers and presenters today. And the Work and Family Coalition works with all of the different issues that are being talked about today. We bring together unions, women's organizations, nonprofits, and other groups to talk about basically what right do we have to put ourselves and our own health first and put our families first and still keep a job and be able to support our families. And it's this basic right that we talk about. Do we have economic security? Do we have equality with other people? And are we able to put ourselves and our family first while still keeping and maintaining a job? So in the Labor Project and with the labor movement and also with the Work and Family Coalition and all the different organizations, we come together to both expand those rights, to build on those rights, and also to teach and empower ourselves and our constituencies about the rights we have. Because just passing a new law, we found, isn't enough, and we'll talk about that a little bit today. It's also really important to empower people to use the rights they have and to make use of them in order to expand them. So this is these are really some important issues, and we have three panelists today. I'll be introducing them as they speak, but we're going to be discussing California's paid family leave, lactation accommodation in California, and also the Affordable Health Care Act. So I would like to introduce Beth McGovern, who's going to talk a little bit about some of the bills that we have passed and some of the things that have happened in the last year.
Good morning. It's good to see you all here. I wanted to give a very brief summary of a few bills that were in the legislature last year that pertain to the issue of maternal health. Two of those bills, AB 210 by Assemblymember Hernandez and SB 222 authored by Senator Evans. I do have the numbers right on that, right? Because it was split into two bills toward the end of the session, and I sometimes have a hard time remembering what those bill numbers were. But AB 210, SB 222, both of those dealt with the issue of maternity coverage in health insurance policies. Essentially, with both those bills, all insurance policies that are sold will be required to include coverage for maternity care services. The real problem was in the individual market. So those are people who don't get health insurance through their jobs. Either they're in a job that the employer doesn't provide health insurance, or might be self-employed people who own their own business, those people who need to go out themselves as individuals and buy health insurance policies. In that market, there was no requirement that the insurance policies sold included maternity coverage. So what was happening is it was very difficult to purchase a policy that did include maternity coverage. So there were lots of women of reproductive age who were not able to buy those policies. They just couldn't find them at all, or they were prohibitively expensive. So a lot of women were going without coverage that they really needed. With these bills now, all those policies will include health care coverage, and that means the cost will be spread among all the insureds, and those policies should be much more accessible. And those bills will be implemented next year in July. Another great bill that was also, those two bills were signed by the governor, passed the legislature and signed by the governor. Another bill that made it all the way through and was signed into law was SB 299, also by Senator Evans. That bill also dealt with maternity coverage and health insurance, but for an entirely different population of people. This one affected those people who do get their insurance coverage through their employers. Before this bill, if a woman were to go out on leave under the state's pregnancy disability leave law, the employer was allowed to terminate her health insurance coverage, so she wouldn't have that health coverage while she was out on a pregnancy-related leave. Seems like probably the worst possible time to be without health insurance coverage and access to medical care, but that's the way it was. Seems crazy, but there it was. So this bill requires insurers to continue health care coverage for women who do go out on maternity leave under the state's pregnancy disability leave law. So wonderful bills that will really make a difference. There was a third bill related to maternal health, not as good a results. That one was AB 568 by Assemblymember Skinner. That bill would have prohibited, in most cases, shackling of incarcerated pregnant women. Unfortunately, that bill was vetoed, but it will be back next year. And so that was, the veto of that bill was disappointing, but we do have these other bills that passed that really are great victories that we can celebrate and that really will be an important benefit to pregnant women and new mothers. Thank you very much, and with that, I'll turn it back over to Jenya.
Thanks. I was just thinking, even when a bill like that is vetoed, it does a lot to raise awareness, because I actually had no idea that was happening. I mean, how many people knew that was even happening? And you did? Okay. Okay, a couple people who knew that was happening. But that's, I really feel like we do a lot of good work in raising awareness, even when a bill doesn't pass, that we still need to, push forward with it and feel like we've had some success in building the movement. So with that, I want to introduce two researchers who have been working on the issue of paid leave. Who will speak next. Eileen Applebaum joined the Center for Economic and Policy Research in Washington, D.C., and she has published widely on public policies and company practices that help us balance our work and family responsibilities, as well as written about wages and employment in industrialized countries, low-wage work in the U.S. and Europe, and direct care workforce. And she's done a lot of work and research that has really helped us understand what's happening with paid family leave, which we're very proud of in California. And Ruth Milkman will be showing this this PowerPoint. She's professor of sociology at the City University of New York Graduate Center and academic director of CUNY's Joseph S. Murphy Institute for Worker Education and Labor Studies. And recently she was also professor of sociology at UCLA, where she directed the research, and also has written and spoken extensively on work and labor issues, especially gender in the workplace, and also has been incredibly helpful with what we know about what is happening with paid leave, and it's really helped us direct our work on that. So here's Ruth and Eileen, or Ruth Milkman.
Thanks, Jenya. Just to keep it simple, I'm going to present the PowerPoint, but we're both available to answer questions later if you have any. And this is, joint research that we've been doing for almost 10 years now. When the law was first passed back in 2002, creating the Paid Family Leave Program, which then took effect in 2004, we saw this window of opportunity to collect baseline data on the program prior to its implementation, and then the idea was, which we've carried out now, to go back some years later and see how it worked out and what difference it made. So we're actually writing a short book on that topic, so that's a coming attraction, but we haven't done it yet. So I'm going to just tell you about our most recent findings as part of that larger project. So as this is going to be tricky, isn't it? I have it here. It's just, but I can't tell what you're doing. So I think you all are aware of this, but maybe not. Now that I've moved to the East Coast, I am particularly aware that California is really the national leader in this area, not just in paid family leave, but in the whole history of provision for these kinds of human needs in legislation. So California was one of 5 states that set up temporary disability insurance. Here it's called SDI, State Disability Insurance, elsewhere TDI, right after World War II in 1946. And that was extended to cover pregnancy as well in the 1970s through a series of changes. So there's only a few other states in the country that have TDI or anything like it, SDI. The wage replacement level here in California is quite a bit higher than in any of those other states. So it's indexed to inflation, and it's currently at $987 a week. That's the maximum. It depends on how much you earn. It's 55% of your normal pay up to that max. I don't have time to go into this here, but you probably are aware of the California Family Rights Act, commonly known as CFRA. That's also an example of California's leadership in this area that took effect in 1992, shortly before the federal Family and Medical Leave Act kicked in. So California, again, led the way. And the KinCare law, which is less well known, and what that does is it allows employees who do have sick leave provided by their employers, not all do, as you probably are aware. If they have it, though, they can use up to half of it to care for a seriously ill child or other family member, which not every place has either. And then finally, the program that we're here to discuss today, paid family leave, which became effective in 2004, and California was the very first state to create such a program. New Jersey followed 5 years later. In both cases, on top of SDI, which can be used for pregnancy, both men and women can take up to 6 weeks of leave to bond with a new baby, including an adopted child or a foster child or a biological birth, or to care for a seriously ill family member. So this is in the United States context, not in other countries where they just sort of giggle when you talk about this because it's so much more limited than what all of Europe has had for many, many decades. But for the U.S., this was a big breakthrough. A couple key features of the program. I'm going to just race through this for those of you who aren't already familiar with it. We got interested in it largely for the reason that it has the potential to kind of level the playing field between professional and managerial workers who usually have not only higher incomes and other resources, but some kind of employer-provided benefits for these situations, not always, but generally, and low-wage workers who typically have no such employer-provided benefits. This program covers the entire private sector in California. Even self-employed workers can opt into it, and so it promised to end those disparities, which are very considerable, as a lot of research, including our own, has documented. The program does not cost employers a penny. It is paid for entirely by a payroll tax on employees, and it's a very modest tax. Unlike the federal law, which offers job protection to certain workers and continuation of benefits, well, that's been fixed now, as we just heard from Beth. This statute did not include those provisions. So there are people who they can get the benefit, but they may not have job security, that the job will be waiting for them when they return, which is a challenge that lies ahead to be addressed. Another feature of the program is it is gender neutral. Both fathers and mothers can use it, and our data show in the Leaves That Pay report, which you should have picked up on your way in, we have a chart that shows that fathers are using it increasingly. Since the program started, it's gone up steadily, the use by fathers, so that's a really good thing. But the bad news is that the take-up rates have been much lower than predicted, and one reason for that is that awareness of the program remains limited, and unfortunately it's most limited among the populations that most need it, that are least likely to have access to other kinds of income support during a family leave or a family, a new baby or a seriously ill family member that requires them to leave their job for a while. So we've been tracking this awareness since 2003, right after the program was passed, but before it went into effect, and a series of surveys. And the most recent one we did, which is the reason we're here today, I guess, included in this briefing, in September, using the field poll folks in San Francisco who were kind enough for a fee to include some of our questions in their field poll that was done in early September. Now, that's a poll of registered voters, and I don't know if you can see these numbers, but they're in the little handout on the field poll. There's actually much more detail in that you should have picked up. What they found was that among registered voters, 42.7, roughly 43% of California registered voters were aware of the program existed. Less than half, in other words. So that's not after all these years. We'd like it to be a lot higher number than that. And as you can see, Latinos and blacks were less aware of it than whites and Asians. Women were more aware of it than men, which is a point I'll come back to. Workers 18 to 29 were less aware of it than other groups, as were people 65 and over. That first one is particularly a concern because many of those people do have children, new babies. And then, can you go to the next slide, please? I don't know if you can see all this from far away, but another really important disparity involves income levels. So people whose household incomes were under $20,000 a year, only 23% of them were aware of the program, and it was a teeny bit higher for the next bracket up. If you jump to the ones that earned $60,000 or more, it's over half. So it's like triple, actually, for the most affluent households, the awareness. And again, they need it. Everybody needs it, but they need it less. So this is the challenge. You can see the same thing with education levels. The least educated workers are the least likely to know about it. And there's some geographic, if you could go to the next one, variation too, which we're not completely sure what's driving that. But LA County actually, I'm sad to say, since I lived there for 21 years, has the lowest awareness of any of the geographic units shown. That may reflect the large immigrant population there. We're not really sure what's driving it. The field poll does not ask a question about where you were born, so we don't know. Union households are a little bit more aware than non-union households, which isn't that surprising, but we can document that as well. Okay, so the next slide is a comparison of awareness today using this field poll from September with the very first awareness survey that we conducted back in 2003. And that's the only comparison we can make because those are the two of the series of surveys we've done that include a question about whether respondents voted in the previous presidential election. So these data are different from what I showed you before. They only include people who said, yes, they voted in 2008 in the 2011 survey, and those who voted in 2000 in the 2003 survey. So the intervals of time between the elections and the surveys are pretty close, and this is pretty much a good comparison, scientifically speaking. So there we see that awareness did increase from only 29.7% for that group in 2003 to 44.9% 7 years later. So that's a significant jump. However, it didn't increase uniformly. Notice it increased a lot among women, which is good, but I suspect the reason for that, though again we don't have evidence of this directly, the Labor Project actually a few years ago persuaded EDD, who were very happy to do this, to send a notice to any woman who had made a claim for STI benefits for pregnancy that she was also eligible for this program, and that may be why the awareness among women has gone up so much. That's a pretty effective way to get the word out. So anyway, for whatever reason, it's much higher among women than it was. For men, it's a little higher. For Latinos, it's gone up too, but remember, this is only people who voted, so it does not capture the large immigrant population that are not citizens or unauthorized immigrants and so on. For other groups, it's gone up a lot more among whites than anybody else. Well, that's not true. Latinos too, but with the caveat I mentioned before, and Asian. So African Americans do not seem to have increased their awareness that much, although it was not as low as some of the other groups to start with. So, okay, now I'm going to sort of switch gears now and no longer talk about the awareness or the field poll, but our other research, which we've been doing, like I said, for ages now, based on other surveys that we've done of both employers and workers, where we're trying to figure out what's going on with this program. So these surveys were done in 2009 and 2010. We did surveys of both employers and workers, though I'm mainly just going to talk about the employee survey today. But the Leave That Pay brochure that you should have picked up has much more detail than I can have time to share with you today. So one question is, why is the take-up of this program as limited as it is? The field poll did ask about that, actually, and among all the respondents who were aware, about 10% had used the program, which means that among all respondents total, only about 5% had used it. Now, that didn't surprise us that much because, A, awareness is limited, but also because at any given point, not that many people have a need for this. Like sometime in your life, you're likely to either have a kid or have a seriously ill family member, but in a given year, a small percentage of workers have those needs. And so that's part of why the program is so inexpensive. Anyway, but there are other reasons why take-up might be limited, and we're very interested in figuring that out. So one is, I've already discussed extensively already, the lack of awareness. Obviously, if you don't know about it, you're not going to use it. And I just said the other reason that's listed here. But the lack of job protection for people who don't have it under some other law like FMLA or CFRA is another possibility, that people who are worried that their job is not going to be held for them if they take a family leave may not be using the program for fear, especially in these times with such high unemployment, that they won't have a job afterward. That's one possibility. And until this law that Beth described kicks in, the fear of losing health coverage is another possibility for those who aren't protected by FMLA, which is only about half of all new mothers, for example. It doesn't cover a lot of the workforce. The other thing is the wage replacement, while again much better than available in other parts of the country, is only 55%, so not everybody can afford to live on that, so that may deter some folks who do know about it from taking it. Anyway, for all those reasons, the next one is awareness, and then for all those reasons, you can go to the next bullet, that like I said before, less than 5% of the field poll respondents had ever used the program, even if they knew about it. Okay, so we did ask in our survey of employees for a very small group of respondents in a survey that covered a lot of other issues, why, if they were aware of PFL and had not used it, why hadn't they used it? And that's this next slide. It's not a representative sample, so this should be interpreted with some caution, but it gives us some clues as to what's going on. So 31% of those respondents did feel that the benefit level was too low, as I already suggested. Another 31% feared, quote, that their employer would be unhappy or something to that effect. In other words, there's some fear still that even though this is the law of the state and of the country to some extent under FMLA, that you're entitled to these leaves, that employers don't like it and might punish you when you return, or might not let you return, even though that's illegal for some cases. So there was some fear of that. And again, in this environment economically, that's probably, even more so than when we were studying it, that's probably a big issue. The next one is related. People thought it would, even if the employer took them back, it might hurt their prospects for moving up in their career in job advancement. Fully 24% of this group feared they would be fired outright if they took advantage of this. So that we got some work to do there too on educating employers. And then finally, another group, 18%, thought it was too much hassle to apply, which I think that must be the affluent folks who, don't really need the money that badly, because otherwise it's not that much hassle. But anyway. Again, those numbers are very provisional, but it gives you some clue about what's going on. Now, let me just say a little bit. I don't have that much time left, so that's why I talk fast anyway, but that's why I'm racing through this. About, for those who do take advantage of the program, this is the good news. It has many, many benefits for working families here in California. So, for one thing, those who use the program, and I'll give you some details on this in a minute, had much higher rates of income wage replacement than those who did not. Not surprising, but it's very important. That's what the program's for, is to sustain you economically while you're dealing with some family need like this. Also, the people who used the program were able to take longer leaves than those who didn't use it, and they were more satisfied with the length of their leaves. They were more likely to return to work for the same employer. And we're not going to talk about this much today, though it's in the report. This is a real benefit to employers because hiring a new person costs money. So anything that keeps retention high is a good thing, and there's a lot of evidence, not just our research, that suggests that these programs, in general, any kind of family leave support, does improve retention. So that was true in our data. And also, finally, the care recipients' situation was helped by this, so that either the new child or the ill family member care was enhanced by people reported better quality care if they had taken advantage of PFL than if they had not. The next slide is kind of a mess, but let's look at it. If you can look at the highlight, it's really the bottom two lines that matter. You can see, can you see it? I don't know if you can see it in the back. Basically what this shows, I'll just highlight the part that's in yellow. In low quality jobs, which are jobs that pay less than $20 an hour and don't have health insurance, or don't have health insurance, those people who use paid family leave received more than half of their usual pay in about 58% of cases, whereas those who didn't use it, only about 20% received half of their usual pay. So the boost to the pay, to the income that you get during family leave, obviously, but particularly for low-wage workers, is greatly enhanced by using PFL. Again, these are the groups that don't necessarily know about the program, but those who do know and do take advantage of it are greatly assisted economically. That's what this shows. And this is in the brochure somewhere. I forget which figure number it is, but you can find it. If the Leaves That Pay report includes this data. Okay, and the other thing is that we show in that same report that the length of breastfeeding goes up dramatically for PFL users. And that's actually true regardless of high quality or low quality jobs. It doubles. So people who use PFL breastfeed twice as long, and we all know that has enormous benefits for children. We looked at a bunch of other health benefits of the program, which I guess this is too microscopic to see in the back, but I'll just share with you that the percent of people who said that this had positive effects on their ability to care for a new child was 82%. And it's higher for those who use PFL, as you'd expect. In the low-quality job group, 91% who used it versus 71% who didn't use it, but might have gone on leave without the program. That's who this is, right? reported that. I already talked about breastfeeding, but both the percent of mothers who did breastfeeding at all and the length of breastfeeding was enhanced by use of PFL, is what this shows. We also asked about the effect on ability to arrange childcare, and that is also higher actually not for the high-quality jobs, but for the low-quality jobs, it's dramatically higher for those who use the program. We asked if it had a positive effect on the person's ability to care for an ill family member. This all seems sort of obvious, but indeed, it did have that positive effect. And finally, on the ill family member's health, paid family leave use was helpful. So that's basically the story, that this is a program that, for those who are aware of it and do take advantage of it, brings great benefits to working families, and the challenge is to increase awareness, which is our first conclusion here, especially to low-wage workers, Latinos, immigrants. The data in the field poll don't speak to immigrants, but our other data do, and we know that their awareness is quite low, and they are eligible for it if they're employed in California private sector jobs. So, and we have. Can I have the next bullets then? There are some people represented here who are in a position to help with this, and we think that one way to get the word out better is through community groups that serve those populations, and we hope that I know the Labor Project is actively trying to make that happen. And also among healthcare providers, it seems to me, every doctor's office, every health clinic should have a brochure about paid family leave there, and the obstetricians and midwives and everybody should give those things out to folks. The WIC agencies who are represented today in this briefing could do this too. And then the other recommendations we make in the report are to increase the level of wage replacement, which I know is not an easy thing to do, but maybe some of you are in a position to try to begin that process. And finally, to extend the job protection. It's great that the insurance is now available to everybody, continuity of insurance, but job protection is another important thing that has not yet been taken care of. And finally, and this we discuss a little bit in the report, I don't have time to go into it now, the public sector is not covered by this law, and we think it should be, because our data show, and this is in Leaves That Pay, though I can't elaborate right now, public sector workers, especially low-wage public sector workers, of which there are quite a few, are quite disadvantaged by not having access to this, and we're able to document that as well. So I'm not quite clear on the reasons why the statute did not include them in the first place, maybe because SDI doesn't cover them, or I'm not sure. But in any case, that would be another very positive thing to do. So I'm going to stop there. Thank you. And we'll be glad to answer questions later. I think he wants to wait till the end. Is that right, Jenya?
Yes. Yeah. I have written comments while you're sitting up.
Yeah, I have.
Oh, thank you.
He submitted some comments.
Okay.
For the record and for everybody who's speaking today. Thank you.
Thanks.
Have a good day. Okay. Thank you, Ruth. The next, I'd like to introduce Karen Farley, who is Program Manager of the California WIC Association, and she's also a registered dietitian and a board-certified lactation consultant. And nutrition and preventative health care are her passions, and I know that definitely she's very passionate about breastfeeding, because when I first talked to her, she gave me the idea that we really need to reach out to a lot more of the breastfeeding groups and link the whole paid leave and taking time off work with the breastfeeding issue, and we've been able to do that in the coalition, and Karen's been really helpful with that. So here's Karen Farley.
I don't have a PowerPoint. Is that okay with everybody if I sit here?
Oh, yeah. You see the little button? Oh.
Yeah. Okay. Okay. Is that okay? All right. Hi, everybody. Well, I was asked to give you an update on what's happening with worksite lactation accommodation, and we're fortunate here in California since 2002. We do have a law that supports that, and out in the foyer there's a list of all the California breastfeeding laws if you want to pick that up, and a brief on worksite and the low-wage breastfeeding in the low-wage worksite, and some information on the federal worksite law, just to tell you what I left out there for you. So anyway, so the law has been in place since 2002, and since that time, basically it's been a grassroots effort on the part of the many coalitions in California, breastfeeding coalitions in California, to get the word out to moms and employers that the law exists so that people tap into it. Just like the Paid Family Leave Act, people don't use that right. And some similar reasons, they're afraid of asking their employer for the right to breastfeed when they come back to work. And for the low-wage moms, and this is we heard this in focus groups that we ran here in California and similar ones that were run in New York. A lot of the low-wage moms, first of all, aren't going back to an employer. They're going to a new job, and it's very intimidating to ask for a new job. Plus, the right to breastfeed, the ability to breastfeed when she returns to work. Or she's just intimidated that she may not be able to keep her job. So a lot of grassroots efforts have been going on with the 44 breastfeeding coalitions, and that work will continue. Then with the Affordable Care Act, we were provided the federal law for worksite lactation. To compare the two laws just briefly, there's some very big similarities between the two. Both laws require that a mom be provided a private place that is not a bathroom stall to pump her milk, and an unpaid break time in which to do that. Differences in the law are that all California employers are required to provide this for moms, where in the federal law, the law applies to hourly wage or overtime eligible employers, and it's all employers in California. And secondly, that employers with less than 50 employees can appeal to the Department of Labor if they feel that this would be an undue hardship to support a mom with this ability to pump when she returns to work. And most importantly, the advocates worked very hard to have inserted in the federal law that the federal law would not preempt state law. So the California law is still just as it was, and we're working off it as advocates just as we were before, but explaining to a lot of people the differences. Certainly the Affordable Care Act was helpful in bringing attention to the law, and it helped more employers see that the law was out there. For a number of years, we've been working with the California Labor Commissioner, whose role is enforcement of the law, but the advocates really feel that in many cases, employers just need education on the law and some technical assistance for how to support a mom in the workplace with breastfeeding, and coming up with some, just some workarounds in their buildings for how a mom could sit down and use a breast pump. So the Affordable Care Act has helped bring awareness to that, and then working with the Labor Commissioner for some enforcement, but also for assistance with education so that employers are aware of the law, and then where to reach out for resources, which at this point are, again, very grassroots places in local breastfeeding coalitions, WIC agencies, and the California Department of Public Health Maternal, Child, and Adolescent branch and the WIC division have a lot of resources for employers. Going forward, and another situation that happened before the federal law came in was that the Office of Women's Health at the federal level was concerned that workplace lactation, which was not previously a law in all states. I believe it's a law in 34 states. But they wanted to advocate for supporting moms going back to work, still breastfeeding. So they developed this toolkit, the business case for breastfeeding, and then provided money to states to go about training, again at a very grassroots level, reaching out to employers, making the case that supporting a mom going back to work is a good investment for their company. It's proven that similar to the Paid Family Leave Act, there's better morale, there's less turnover, moms are more productive. Obviously, moms and babies are sick less often, so healthcare costs are reduced, and moms are at work more often. So that work's been going on for about 8 years, and now with the Affordable Care Act and the federal law, Office of Women's Health has put some more money into another toolkit, and I'm pleased to say that California is going to be working on this federal toolkit, and it will be directed to more of the non-traditional work site, and there's still hourly wage work sites that are very high paying, but trying to hit work sites where there are low wage workers. And so a national compendium is being developed that hopefully employers will be able to go to on an online basis and look at similar looking companies where they can see themselves, and with some video footage and photographs where they can look at how a worksite lactation station is set up and hear about how employers have done this, either on a temporary or permanent basis, depending on what the employee needs are there. So that's going to be happening over the next 3 years, and there will be some really nice intensive case studies posted from across the nation, and then follow-up trainings to assist employers. We just met yesterday with the Department of Labor, and they're very much working collaboratively with the Office of Women's Health, and really wanting to be a good partner in this. So it's very encouraging that the materials will be good, and the Department of Labor is on board. As I mentioned, they've already got a really nice fact sheet for employers out there, and they're taking lots of comments. They have been taking comments and trying to do really good FAQs so that they can be prepared for employer questions and employee questions. And so it looks like it's got a good path forward to try and get word out to employers. And then, of course, trying to get word out to moms. And it's still been very much grassroots through community clinics, WIC sites, hopefully physicians' offices. And then here in California, at least through the breastfeeding coalitions, the U.S. Breastfeeding Coalition, which has broader and deeper reach as the years go by, is working with the other states to try and get word out. So that's sort of where we're at with worksite lactation in a nutshell. I just brought a sample. This is a very high-quality breast pump. This is a pump that multiple mothers could use. It's a pump that would help a mother establish a milk supply if she was having trouble establishing a milk supply, and certainly maintaining a milk supply once it was established. There are all varieties of breast pumps. Some are very good and some are really not that useful. But mothers can access these pumps in a variety of ways, either through their WIC agencies if they're a low-income mom. For those moms that are in a situation where they're paying taxes and can take a federal benefit for breast pumps, it's now a federal benefit for tax pumps. It doesn't for breast pumps. It doesn't necessarily apply to a lot of the WIC moms that is in our purview. And then some employers will provide pumps. My employer provided this pump to employees who, this pump will last for years for future employees who want to breastfeed. I know the University of California, Davis provides pumping stations with pumps, and moms just come up with their individual parts and hook up and pump. So it depends on how much foresight and vision an employer has in investing a comparatively small amount of money to keep their moms and babies healthy, and keep the moms working in the work site. We're very hopeful. Additionally, with the Affordable Care Act and all the discussion now on the essential health benefits, that the counseling for nutrition and breastfeeding remain in the health plans when all the negotiations come down about cost first coverage, because it's not just about breast pumps. As lactation consultants, we want babies on the breast as much as possible, not tapping into breast pumps per se, but using them only when needed. And that's where the other half of breastfeeding is important, and that's somebody to talk to help you problem solve and get support. And historically, in California, that was supposed to be Medi-Cal, and for a variety of reasons, WIC became the default. And we've been working on flip-flopping this, and Medi-Cal is now improved, and the regulations should begin to work, and we're piloting those around the state, and didn't know that health care reform was coming. And so we're very hopeful and doing everything we can to advocate that those counseling benefits in the essential health benefits under the preventive services for breastfeeding, and as WIC nutritionists, the nutrition counseling benefits are provided in the health plans when moms open up their plans or look online, and they know they can talk to somebody and get help and problem solve. So that's our next real concern as far as supporting moms with their lactation, whether it's worksite or other needs. So anyway.
So I think Alina is going to sit here. You know, it takes a lot of support to breastfeed. We got a call a little while ago from a firefighter who, when she was pumping, she had to use the chief's bedroom. And, you know, she would have to tell him that she needed to use his bedroom and then kind of perch on the end of his bed. And that was really hard because she was the only woman and the only person using a breast pump in the whole place. But so I would like to introduce Alina Salganikov, who's the Vice President and Director of Women's Health Policy for the Kaiser Family Foundation. And she directs the Foundation's work on health coverage and access to care for women, and especially low-income women, women who are underserved, who are on Medicaid, and women of color. So Alina is going to stay here, though.
That's okay. Despite my many years as a mother, my vision in the back of my head is not that well developed, but it's good. So I'm just going to stand up here. It's interesting to hear these different presentations in terms of thinking about once you have the law, how challenging it is to implement a law. And I would say that compared to the Affordable Care Act, what the laws that you were talking about are a piece of cake. And so this is critically important. All of these are critically important protections for women. What I want to do is kind of quickly with my time try to kind of walk you through some kind of basics of the Affordable Care Act. You've seen the pictures of the law and everybody complaining that it's 2,000 pages. We're talking about a law that affects 17, 18% of the GMP in this country. It's an incredibly complex system. So if you're confused, that's okay. It means it's starting to penetrate. It'll take a while. So I just want to change the channel now to kind of focus on healthcare, moving away from health. And we're going to see if we can walk through. So what I want to do first is kind of give you a little bit of background on kind of some issues here in California. I'm going to talk then about how is the Affordable Care Act going to help uninsured women and ensure continuity of coverage, and then talk a little bit about how health reform may affect the scope of coverage and quality of care for women who are already insured, and then kind of drill down a little bit on some key issues around maternity care, around eligibility and enrollment, scope of benefits and affordability, and then I want to kind of come around to the safety net and women who are likely going to be uninsured after the implementation of the law. So first, talking a little bit about what's going on in California. Go to the next slide. So as you can see here, California tracks pretty closely on looking at prenatal care use, health care outcome, birth outcomes. We do a little bit better on almost everything, which is good because those of us in California, we take pride in really kind of being on the cutting edge. But as you go to the next slide, there still are tremendous disparities. And I could show this on every single measure that's up on the earlier slide. And these disparities by race and ethnicity and by income, education, however you want to slice it or dice it, are still there and quite persistent. So this is looking at initiation of prenatal care, but if you go to here in California, this is from a recent study that looked at maternal mortality, which is a very rare event, but if you look here, the scale is off the charts for African American women. And this is a very, very, although not large in the population, a really devastating and largely avoidable condition. So as we're moving to maternity care, and I'm going to focus more on coverage policy rather than actual provision of maternity care services. In the United States, where we are, this is prior to the passage of the ACA. We have the Pregnancy Discrimination Act, which mandates basically coverage of maternity care in group plans, and also we have the protections against, remember, the drive-through deliveries, so that you have to have a minimum of 48-hour hospital stay after a vaginal delivery and 96 hours after a C-section. And that's it. That is it for federal protections for maternity care, okay? And so in the individual market, there's really no protections. And as we know, we heard here in the battle in California over coverage of maternity services, if you wanted to buy it. Sometimes you couldn't. Sometimes it's considered a pre-existing condition. So because you were pregnant, you were disqualified from having maternity coverage, or you had to pay for a rider, which was sometimes as expensive as the insurance coverage. The premiums also in the individual market were often subjected to gender rating. We didn't talk about that earlier, but that actually is also legislation that was passed here in the state, and gender rating has also been banned. Gender rating is when women have been charged more than men for the same insurance coverage, even though it doesn't include maternity care. And so that is actually has been banned under the Affordable Care Act, but California was ahead of the pack on this, so they banned it as well. In Medicaid, there is a floor. All women under 133% of the federal poverty level are required, all states are required to extend coverage to those women. States can and go, and most actually do go higher, and I'll talk a little bit about California. Medicaid is the largest payer of births by far. It pays between 40 and 50% of births in the country. In Medicaid, pregnant women are exempt from cost sharing of any type. States also can adopt policies, and many have done, in terms of presumptive eligibility to make sure that when women show up for prenatal care, they're quickly assessed, and for outpatient care, they're assessed eligible. There's enrollment in hospitals, and Medicaid has often an asset test so that if you own a house or a car, sometimes you're excluded. Not the case for pregnant women. States are able to waive it, and I think the majority of states do. But it's important to know that Medicaid eligibility goes to 60 days postpartum. And unless you qualify under another eligibility pathway, your coverage as a new mom is basically terminated. So that's been a real limitation. And in Medicaid, there's been a lot of churning. Women are eligible when they're pregnant, then they're not. And we all know a healthy mom is critically important when you want to have a healthy baby and a healthy child. So in California, we heard about the SB 222 and SB 299 earlier. These are really important and very important advances. Also the banning of gender rating. In California, Medicaid eligibility is extended to women up to 200% of the federal poverty level. That's around $44,000 for a family of four. And it pays for 46% of all births in the state. We also have a program called AIM, which covers women between 200 and 300% of poverty. This program largely exists because the individual insurance market did such a bad job. So many women were either uninsured who were in this group or underinsured and were not covered for maternity care. So it's not going to be clear what's going to happen with this program moving forward as we implement the Affordable Care Act, and we will have much broader universal coverage. I keep wanting to click this to move it forward. So just to give you kind of an overview, and I know you've all heard a lot about the individual mandate. The Supreme Court is going to be hearing whether this is constitutional, but individuals are going to be required to purchase plans that purchase or employers provide have coverage, minimum coverage standards starting in 2014. This mandate is going to be enforced through the tax system, and there'll be monetary penalties for those who don't either have coverage through their employers or to purchase coverage. There are exemptions. American Indians, undocumented immigrants cannot get insurance either through the exchange. They will have to either buy it separately or remain uninsured. And certain low-income individuals, if they show it's a financial hardship, or if you have religious objections to insurance, you can be exempt. Medicaid will be expanded for all individuals who are up to effectively 138% of the poverty level. So just to give you a little background on Medicaid, and Medicaid's kind of the program like here, Medi-Cal, the more you know you don't know about the program. There are different eligibility categories, and if you fit into a category, each of those eligibility categories has a different income eligibility. So parents of dependent children, those under 18, pregnant women, people with disabilities, people over 65, fit into the categories. But if you are an individual who does not have a child or not pregnant and is not disabled, you will not qualify no matter how poor you are. There are states that do expansions and exemptions, but that is kind of the federal law. The ACA will change that, and everybody, it's just going to be an income level. You're going to be able to get your insurance through a state-based exchange, and California was the first state to pass enabling legislation so that we could start an exchange. We have a 5-member appointed board, and we have a new executive director, Peter Lee, and we've already, in California, already taken in, I think, over like $40 million in implementation grants for the exchange. So we are on the front edge of this. There are premium and cost-sharing subsidies for those who qualify based on income and citizenship status, and you'll be able to access these through the exchanges. So there are going to be tax credits and assistance basically to people up to 400% of the poverty level. So it's going to be a sliding scale, but basically that's estimated to be around $94,000 for a family of 4. So all of those families will get some level of assistance in terms of purchasing, getting your premiums. In addition, there are going to be cost-sharing subsidies for low-income families, those above 100 to 250% of the federal poverty level, to offset some of the costs for out-of-pocket costs. As many of you know, the premium is your down payment on insurance, and then you have to keep paying in terms of the out-of-pocket costs. So in California, what does this mean for women of reproductive age? About 1 in 4 women of reproductive age are uninsured in California. So this new law has the promise to really assist a lot of women. That's about 1.7 million uninsured. I don't know if you can see in the light, about 60% of those women are going to be estimated to be eligible for Medicaid. This is because women of this age, and particularly uninsured, are disproportionately low income. About a third of them are going to qualify for either some tax credits to help them get the subsidies, and about only 6% are going to be able to get insurance on the exchange. So you're going to have there's all of the exclusions around pre-existing conditions. All of those are going to be banned. So everybody, regardless of their health status, is going to be able to access the exchange. Those women in the 6% will not get any level of subsidy. Go to the next slide. So we have all these women going into Medi-Cal, and Medi-Cal, as I'll talk about later, has some very good coverage for maternity care. And we kind of have a little bit, I love Google Images, you just plunk something in and it comes up. And this was my split personality image, and you can see in California there's a lot of optimism right now with the Bridge to Reform waiver that we've gotten from the federal government, which really allows for county-based expansions for low-income adults, and a lot of counties are stepping up, and we've had some really important expansions under Medi-Cal so that individuals who have not historically been eligible have been. There are plans to transition seniors and people with disabilities into managed care. And then there also is additional financial support for public hospitals who meet certain quality improvements and measurable outcomes. But on the other side, I don't have to tell this group that the budget shortfalls have been just brutal on every public program, and Medi-Cal is not an exception. They recently got federal approval to implement payment reductions to providers, another 10%. You should know that California is really at the bottom in terms of provider payment reimbursement, and even per capita spending on Medicaid beneficiaries, so that there's a lot of concern in terms of where there'll be adequate supply of providers available to serve all of these individuals. There are also proposed, it hasn't been implemented, increases in cost sharing, $50 for an ER visit, $100 to $200 for hospitalization. I recently found out that this also includes hospitalizations for childbirth. So, which was, I was a little surprised. They're requesting a federal waiver because, as you remember, I said earlier, pregnant women under federal law cannot be charged any copays or cost sharing. There are also significant cuts to adult day health and in-home support services, and I'm just thinking now about what those cuts might mean to women who are taking paid leave to care for frail or sick relatives, because any type of respite or other services is really going to be scaled back. And also a proposed 7-visit limit on physician services. Now, while pregnancy-related services are exempt from this, other services that pregnant women may need may count towards these 7-visit limits. So this is the hard reality that the budget has now forced us to face. In terms of the scopes under the services under Medicaid, and this is a survey that the foundation did a couple of years ago, looking at what are the maternity care benefits that Medicaid provides. You can see that California provides all of these coverage for breast pump rentals, lactation consultation, substance abuse treatment, childbirth education, genetic counseling, preconception counseling. But as you can see, not all the states cover all of these issues. So we're pretty fortunate that we have such, I think, good advocacy and support from here. In terms of kind of non-coverage benefits, there were some other benefits in ACA that I just wanted to mention. One is the mandatory coverage of tobacco cessation for pregnant women, which we would think is kind of a no-brainer, but in fact, a number of states did not pay for tobacco cessation for pregnant women. Now it is the law. There are also going to be some investment in the development of quality measures for maternity care. There's been a lot of investment on measures for quality for children, but not that much for adults, and I think maternity care is an area where it's really been lacking. Now there's going to be optional coverage of freestanding birth centers. That in many states, they had decided they were not going to pay for births that happened in birth centers. That was a devastating financial blow to many freestanding birth centers. And also incentives to eliminate cost sharing for preventive services for adults. I'm going to talk a little bit about that in a minute. There are also new grants for states to do maternal and infant and early childhood home visiting, and new grants for interventions to look and to assist individuals who are at risk for postpartum depression, so women who are at risk. The law says individuals, but it's women and their families. And also increased payments to nurse midwives under Medicare to 100% of the physician rate. It was 65%. And why this is important is because so many insurers base their reimbursement rates on Medicare rates, and so they were paying nurse midwives significantly less than doctors. So while there are very few births that are paid for by Medicare, the Medicare payment rate sets the standard for what insurers pay. And we heard earlier about the fabulous new workplace breastfeeding protections for pregnant women. If we go to the next one. So if we talk about benefits, I had the great honor and privilege on sitting on the IOM committee that came up with the recommendations for the preventive services for women that are in health reform. There are kind of two sets of benefits that people talk about around health reform. The first are the preventive services, and the other are the essential health benefits. Those are two distinct provisions, and I think it's really important to recognize that. The Affordable Care Act stipulates for the first time, remember I said there were only 2 maternity care? There are 4 altogether federal rules around coverage. The other is around mastectomy, surgical, I'm like completely, but after mastectomy to have reconstructive surgery, and the other is on mental health parity. And that's it. That is it in terms of insurance requirements at the federal level. And that's because the state usually regulates insurance. And we have a lot of mandates here in California. But the states regulate the business of insurance. So any plan that's bought or sold in the state, what individuals buy or sometimes small employers get, those are regulated by the states. But these large self-funded plans, and 59% of workers are in self-funded plans, are regulated at the federal level. This is going to change that in a really dramatic way, because now all new private plans, and that's the self-funded plans, individual ones, employer, everything, those that are bought and sold, and those where the employers pay for services directly, are now going to be required to provide a broad range of preventive services. And these are those that are recommended A or B from the U.S. Preventive Services Task Force, the immunizations that are recommended by the Advisory Committee on Immunization Practices, all of the Bright Futures guidelines for preventive care and screenings for children, and then with now new benefits for women. that this was the IOM committee came up with these recommendations. 2 weeks later, HHS accepted all of those, and those included contraceptive coverage. It included breastfeeding support, lactation counseling, and education, as well as the cost of breast pump rentals now must be covered, intimate partner screening and violence screening and counseling, HPV testing for pap smears, I'm trying to like a quiz, and STI screening. So there were quite a bit of other services. If you go to the next slide, you can see this is a list of all of the preventive services that will be covered, and I'm really sorry that it's so small. And we have the Kaiser Family Foundation. If you actually go to kff.org, we have a brief that actually goes into a lot of these in more detail. But this is unprecedented, that plans now will have just a huge coverage of preventive services. This is first dollar coverage. The plans must cover it without cost sharing. So this is really important. If we look at the pregnancy-related services, this includes preconception care, well women visit. Those were also part of the recommendations, folic acid supplements, as well as contraceptives before pregnancy, pre-pregnancy, everything from prenatal care to a wide range of screening and counseling services, and postpartum breastfeeding supports, as well as contraception. So these are really important new changes. However, if we look to the essential benefits plan, and this is the plan that will be offered by those plans that are sold on the exchange. This is basically the detail that we have. The good news is that maternity and newborn care is on the list. But as we know, amount, duration, and scope are pretty important. And so I think it will be really, really important to keep our eye on that. The breastfeeding supports are part of the preventive, so they are going to be in these plans. But as we know, the implementation, education is all going to be a huge challenge. So HHS has to make a final determination on that. It's anticipated that we're going to get something in the late spring. There was another IOM committee that made some recommendations on the process for establishing benefits. And what's important to know there is that they recommended that HHS set a dollar target. And that this should reflect the current average cost of small business health insurance plans. Well, we don't really know what's in the average small health insurance plan, but we know that it's typically smaller than what a large business provides. And so that's something that concerns some of us. Also, that the state insurance mandates in California has quite a few of them, not automatically be included in there. So for the state, so that's an area that I think is of concern. HHS is having some listening meetings. I think there's one coming up in San Francisco pretty soon that they will be wanting to get community input in terms of what are the benefits that should be included. So if we go to the next slide, I just can't go in all of this, but you should know that the family planning and contraceptive coverage wasn't included in the essential benefits, but now it's in the preventive benefits. And that's not only for uninsured people, it's all new plans. And when I say new plans, it's plans that will either new plans that people buy, plans that are sold on the exchange, and also any plan that changes. So if your plan increases your cost sharing or your deductible or your benefits, it's considered a new plan for these purposes. And it's anticipated that even by 2014 there will be 90 million people in new plans. So incrementally this will be increasing. The other issue that I think got a lot of attention is abortion, which I think if we talk about women's reproductive care and pregnancy-related care, it's important to consider abortion. And the way it's structured right now, it cannot be included as part of the essential benefit plan, but it can be sold on the exchange. People will need to make 2 different payments. We're in the process of figuring out how that's all going to work. California is a state that has the Reproductive Privacy Act, so that plans have to offer coverage. So in terms of implementation, it's just kind of a matter of trying to figure out how it's going to be structured. In addition to that, there is new coverage for, as I mentioned, STIs and HIV, which are really important. The one thing that I did want to mention, and I've had conversations with Terry Thorfinson, who's the chief of the Office of Women's Health, For the preventive services for women and all of the preventive services, with the exception of the preventive services for women, there is not a requirement that Medicaid cover these benefits, but there's an incentive in terms of an increased 1% match. The women's services are not included there. So Medi-Cal covers family planning and many of these other services, but not all. And now with the concerns about the increases in the waivers on the cost sharing for pregnant women, I think that that's an area that really merits careful scrutiny and monitoring over time. And then finally, I just want to touch on affordability, because I think it's really important. It's really great that we have this new expansion, but it's only going to work as long as it's going to be affordable for people. And even with the subsidies and the cost-sharing assistance, there is some concern that it is not adequate. As many of you know, when you're developing policy, it's not like you develop a policy and you fund it for what it's actually going to cost to implement. When Congress was given the instructions, the president said it has to cost $900 billion over 10 years, and they backed into that. And a big part of the subsidies, the expanded subsidies, did get scaled back. If you look at uninsured women, 56% of them have incomes below 139% of the poverty level. Those women will go into Medicaid, but the cost sharing is important. But a significant share of other women are also low income, and in fact, 1/3 of all women of reproductive age have incomes below 139% of the poverty level. If you go to the next slide, you can also see that, and this is a finding from a Kaiser Health tracking poll, but we find this all the time, that women are much more likely than men and consistently more likely to report that cost is a barrier to care for themselves and their families. And so that this is an area that I think we really, really need to be cognizant of as we're developing policy. And then finally, who's going to be left out? And, you know, I think that it was kind of near universal. I think people have a sense that it's going to be vast coverage. But the CBO, when they were doing their estimates, they estimated that 23 million people will still be uninsured in 2019. In California, there have been estimates done, and they estimate that in 2016 there will still be 3.1 million people who are uninsured in the state. Who are they? Clearly, many of them are going to be immigrants who are not legal residents. You're going to have people who are eligible but not enrolled and very hard to reach. People who are exempt from the mandate for whatever reason, or because they can't find affordable coverage, or people who basically choose a penalty in lieu of getting health insurance, and there will be those individuals. I'm guessing that most of those uninsured are going to be low income, and at the end of the day, when they get sick, they will show up at emergency rooms and at clinics. And so having a robust safety net is going to continue to be essential as we're moving forward. Family Pact, which is the state-funded family planning program, is of critical importance to women in this state, and I think will continue to be in the future, but also looking at support for public hospitals, federally qualified health centers and rural health centers, and also family planning providers will also be important. So, you know, at the end of the day, we I think still have more questions than answers, and just laying out a few of them in terms of enrollment, in terms of coverage, scope of coverage, looking at the reality in terms of the budget cuts and what Medi-Cal looks like now and what it may look like in the future is important. Looking at the safety net and undocumented women in particular, when you look at maternity care and affordabilities and provider availability, we could spend days talking about this, and I know people have been. These are really, really important issues, and you know, I'm thinking we're building a new system right now, and so there's great opportunity, but we need to be very careful as we're moving forward.
So I want to open it up to questions. Does anybody have a question? To anybody in the panel?
I have a question, Alina, for you. When you were looking at who was exempt from being covered by this insurance, you mentioned American Indians. Does that mean all American Indians?
They can buy, in terms of whether it's on reservation or I can't answer that exactly, but they're exempt from the mandate. It doesn't mean that they don't qualify. Okay,
Oh.
so that's a distinction. They could buy on their exchange or qualify for Medicaid, but they don't. They're not required to. Yes. Okay.
Yeah. So that was a sovereignty issue. Okay.
Yes.
So this is kind of for any or all of you. I recognize that sort of at least part of the philosophy behind the breastfeeding and paid medical leave programs is to foster attachment between parents and children. Do the services now or will future services include specific counseling or education about the importance of that young, that new child-parent attachment, particularly in light of growing research regarding the correlation between attachment and mental health disorders?
Does anybody?
I'm not sure I fully understand your question, but are you trying to make a connection between?
Well, I'm just wondering. There's a growing opinion that there are connections between early childhood attachment and future mental health disorders.
Right.
And I'm just wondering whether there is currently a focus on, or there's expected to be a focus on specific education regarding the importance of attachment.
Okay, just speaking specifically about breastfeeding counseling, those who are trained to provide breastfeeding support, it's how you answer, all that is provided when you provide breastfeeding support may be on the surface, a problem-solving approach to helping a mother reach her goals for whatever it is she's set out to do with breastfeeding. But in delivering those services, a well-trained professional will help the mother learn about parenting and bonding and understanding her baby's cues and understanding her attachment to her baby and her responses to her baby. So, yes, indirectly, just because the profession requires that you have that understanding, if that helps you in that question. And regarding having time to be with your baby.
Yeah, I just wanted to speak briefly to that. So part of the benefit of the paid family leave, or any family leave for that matter, is that we know attachment is enhanced by people getting some time off from work to be with their new babies. And I'm not an expert on the mental health dimensions of that, but there's a lot of evidence that it has multiple benefits in all sorts of arenas, including the one you're concerned with. So paid family leave is another tool to enhance that. People are more likely to take a longer leave, et cetera, women in particular, if they have access to that and know about it, et cetera, all the things we spoke about earlier.
I think that the body of evidence on the benefits of breastfeeding, including attachment and all of the health benefits, is just, I was stunned when, being on the IOM committee, just reviewing that, just how powerful it is on so many particular dimensions of health, mental health for the mother, for the child, physical health. It's just, it's staggering. And it is really kind of, when you think about initiatives that we should be supporting in terms of promoting and improving health and well-being of women and children, it's just really a good value all around.
In the back, please.
Can you give a little more detail about what we can expect to see in May 2012? What is it that they will be doing?
On the essential benefits package? Well, I don't have a crystal ball at all, and I've heard a lot of different things. And, part of the reason that they just kind of came up with a list like this is, I think, during the Clinton reform efforts, it was just a major food fight. on the Hill, and just trying to get anything agreed upon in any level of detail was extremely difficult. And clearly the essential benefits, there's kind of a tug of war going on, because you want to keep the costs down, because as the costs are, as they go up, it's clearly going to be passed on to employers and individuals. And you want to make sure that it's meaningful coverage. I mean, my big fear is at the end of the day, we're going to have kind of an outline, and you're going to have basically high deductible health plans with sketchy benefits and a lot of first dollar coverage for preventive services. And, you certainly don't want that. So, in terms of what HHS will do, some people believe that they're not going to do a lot of detail. They'll have something a little more sketched out than this, but not much more as a floor, and encourage states to go further. A state like California will likely go further, and we have a lot of requirements, but you can see some other states may just go with the minimum, like the states that are choosing to step away from even creating the exchange today. They came out with the news that South Carolina has decided they don't want an exchange. And so they're going to leave it up to the federal government to do that. So, you're going to have kind of a wide variation in terms of what's there. But
there was a question up here?
Well, I was at a meeting earlier this week with Alina, and I'm going to ask a similar question. You all have talked about really important things, and you've made some recommendations, but for us, in closing, could you just say what you wish we would do as it relates to these important issues? What actions we as individuals here?
Can I ask you one more question, though, based on her question back there? So what we're concerned about, and maybe you can help clarify this, is that when they look at that essential health benefits package and they're saying, well, ambulatory care costs this, and lab services cost this, and then there's preventive services, and then under preventive services there's all the required things we're supposed to get. We're afraid, and this sounds really jaded, but in the end, what they call counseling could be a phone call to an 800 line, or, you could define those preventive services in a number of ways, and then if they're such that they're not really effective, then it gives people reason to say, well, see, those preventive services, we didn't get our bang for our buck there, and then we could be set up for losing them. So the advocates are very
well, but the choice is you don't have it at all, right?
Yeah.
You've got it, and so the question is, I think worrying about whether they're going to take them away, we should be we've got them, how do we grab them? Should be the framework, and then so the question I think is a really good one, because they're the very broad frameworks, and even under the preventive services, ones that will be required. There is an important issue related to oversight, and who's going to oversee to make sure that these preventive services are provided. And is it going to be the state? Is it going to be the Department of Labor for the ERISA plans? Is it going to be HHS? Because right now the jurisdictional issues are divided between all three of those. But I think that it's going to be important for advocates to be pushing to make sure that the definition is broad, employers to demand it, women to demand it, and I think for policymakers to hear how important, why these are important benefits, like the breastfeeding or any of these benefits, why they merit special attention. Because I think you're right. I think counseling is can be a very broad definition. When we were coming up with these recommendations, we very clearly put language in there that it should be people who are trained individuals. So it can't be just somebody answering a hotline. It needs to be somebody, and HHS adopted that. So again, that takes you back to the enforcement issue, which I think will be a really important one.
So is there one more question, and then I'd like to do what she was suggesting about going around. Is there any other questions for the group or for any individual? So I think that's a good idea, in closing, maybe to talk a little bit about policy. Just, we're here, people are advocates and legislative staff, and it's good for us to hear sort of what your recommendations are that we do in the field with the work we're doing.
Can I start? Do you want us to start? Whatever. Why don't we just go around?
Well, I can just tell you what we're asking our advocates to do. And that is we're asking them to get to know their health plans in their communities and develop relationships with them. And we have a few test projects going on where we're tapping breastfeeding benefits and connecting community clinics and WIC sites so that it's not just tapping the benefits, but it's making all the partners talk to each other and provide the counseling and provide the referrals and share, basically build a better safety net. So if a mom skips an appointment in one place, she's seen in another place. But the basic message when our folks are asking us about what about the Affordable Care Act, what we can do, is we're asking them to read about it, and we're funneling them information and trying to make sure our members have information. And we're very thankful to the Kaiser Family Foundation. They have excellent materials that you can forward to your members. And then asking our people to go talk to your health plans and find people in there who are going to be providing member services and talking up nutrition and breastfeeding in this case, and building those relationships and making the case. So that's what we've asked our folks to do. So.
I already spoke to this a little bit in the final slide, but I'll just repeat what I said there. So there's sort of two things that come out of our research. One is the huge need to expand outreach about paid family leave to the groups that are not currently aware of it, and especially those that are most in need, which would be low-wage workers, Latinos, immigrants. And that's something advocates could do. It's also something those of you in a position to create new legislation could mandate, especially like the idea we had was perhaps it could be required that healthcare providers have the paid family leave program brochure available to any new anybody caring for a seriously ill person or a pregnant person. Right, pregnant woman, I guess that would be. But we'll see. There was that movie with Arnold Schwarzenegger. So, anyway, and then the other thing in terms of new legislation, and I know this is a much bigger ask, but it would be great to increase the level of wage replacement in the SDI and PFL, to extend job protection to everybody who uses it, and expanding coverage to the public sector, as we mentioned before. Those are the obvious ones, and maybe Eileen wants to add a few others.
Not for California.
Just push the button. Yeah.
I did, but it's not.
Oh.
It did a weird green thing. I think we can hear
You can use this one here.
Yeah,
I think you can hear me. Okay. But I think also, I know this is California, but there are efforts in other states that I think need to be supported. And one of the things that has been in the president's budget, it hasn't ever actually made it through the process, but he does keep putting it back in the budget, is a small fund that would do two things. For states that don't already have paid family leave, it would provide startup funds for a state that wanted to do it. The idea being that, so California and New Jersey have it, but these are states, of course, that had SDI programs. So it was easy to see how you're going to expand, not easy to make it happen, but you could see how to expand it. But what about a state like Washington State that's passed paid family leave but doesn't have a mechanism for funding it, or Oregon that's considering it, or Maine? So the idea is to provide these states with startup funds, and let's see how they're going to do it, and let's see what we can learn from that. And so that we don't discriminate against the states that have already started these programs, the funding would also be available for the outreach activities that Ruth is talking about. So New Jersey, where I was from until a year ago, has very similar issues in terms of outreach and public education and making sure people know that it's available. So these two states would like to have funds to do a better job on outreach, and the other states would like to have some funding for the initial startup and administrative costs.
I'm struck by listening to all of these, all of our presentations. I think one of the really important things that we all need to do is educate the constituents and the people who could benefit. The Kaiser Family Foundation does a tremendous amount of polling. We've had at the same August poll we had some really disturbing findings on the number of uninsured who think that they're going to be harmed or not helped by health insurance. You've got 40% of seniors who think there are death panels when there aren't any. There's a lot of confusion, and so to the extent that people can hear that there's going to be, help is on the way, I think is important. I think in terms of policy, I think that the people who need to be educated are constituents and policymakers. This is incredibly complex, and it's the interaction in terms of healthcare of federal policy, and there's still a lot of questions, as we have heard about the essential benefits, but then kind of what we build in California. And I think to the extent that we can build something really strong and positive, that we have a great opportunity to do that. But the policymakers need to hear, both in terms of those who are on the exchange, the committee that's building the exchange, as well as legislators and the governor need to hear what is important, particularly for those who don't always have a voice.
Thank you. Okay. And thank you everybody for coming. In closing, too, I wanted to say that we are the Labor Project works with and the California Commission on the Status of Women works on a statewide coalition, the California Working Family Coalition, and we work on all of these different issues. And one of our big tasks right now is educating even the member organizations of the coalition. So those are both unions and other community organizations that have joined on what we have now. And it really gives people a very clear understanding of where we need to go next, because our leave laws and the laws that cover us when we need to take time off to care for ourselves, a close family member, or bond with a new child are very complex, because one person might have job protection and another person might just get only the money. But if you didn't sign in, there's a sign-in sheet on the outside, and you can circle something if you want to get emails about upcoming events or trainings. So thank you very much for coming, and the briefing is over.